and gentlemen, we'd like to invite a next speaker. Our next speaker is currently serving as the Director of Lupus Clinical Research at the National Institute of Arthritis, Musculoskeletal and Skin Disease, which is a branch of the National Institutes of Health at Bethesda, Maryland.
He has trained in internal medicine and rheumatology at State University in New York at Stony Brook and completed Masters of Health Sciences in Clinical Research from Duke University.
He is a recipient of the William G. Coleman Research Innovation Award. He has also received the National Institutes for Health Directors Merit Award. He has served as the chair of the Scientific Review Committee for the United States Department of Defense.
He has congressionally directed medical research programs and has authored several articles published in high-impact factor journals and has contributed book chapters to rheumatology textbooks as well. Ladies and gentlemen, please welcome Dr. Sarfaraz Hasni.
Okay, thank you so much for the kind introduction, and thank you to the conference organizers for giving me opportunity to come here. So, of course, you know, I'm born and raised in Karachi, so love Karachi. Yay. All righty. So, always a pleasure to return back to Karachi, and very nice to see the audience and students and everybody. So, these are my disclosures. These are my personal views, not associated with the organization that I work for. And this is some of the study criteria that I have used, and I looked at the publications which are between last year, September, up till now, because I was given a task, a rather huge task of both lupus and vasculitis, so tried to use those terms. Didn't use early phase trials because those are sometimes not so useful. And then the studies that can be used in some local context. And of course, if I miss your favorite study, I apologize. It's my personal selection, and it's by no means mean to be a comprehensive review, which obviously we won't be able to do in that short period of time. So with that, I will start, and I think no study in review of lupus can be completed without talking about the CAR T-cell therapy, and is the greatest buzz around these times. So this was the follow-up study. I think Michelle has talked about it a little bit during her talk. For the medical students and those who are not so familiar with the CAR T therapy, I just use this cartoon. So just kind of do a quick overview of what CAR T cell therapy is. So if you go from number-wise, so the first thing is that, so basically the idea of the CAR T cell is that it's sort of called the living therapy, where you use your own, patient's own T cells to attack the B cells, which are making all these autoantibodies, and the idea is to do a complete wipeout of all those B cells, so those autoantibodies will not be made, hence would not be causing the pathology or the pathogenesis of lupus. So the first thing what we do is that we do leukapheresis and take out the cells out, and those T cells are then engineered by using some kind of a virus vector, usually the lentivirus vector, are inserted in the genetic makeup of the T cells. And then those T cells start expressing those chimeric antigenic T cells, which are either receptor T cells, usually the ones that are being used are against the CD19, which is a pan B cell marker here. And those T cells are then expanded, and then once they are expanded, then the patient goes through a lymphoablation therapy, usually by fluci therapy, which is fludarabine and cyclophosphamide. And once the immune system is totally wiped out, those T cells are then infused. And when they are infused, then they go and multiply, and then wherever the B cells are hiding, which have not been wiped out through with the ablation therapy, will be killed by the CAR T cell. So that's sort of, in a nutshell, a very brief overview. Obviously, it's a much more complicated concept than what I have just described. So based on this concept, George Schett and his group has reported the first case in New England Journal, and now the same group has now reported the 5 cases of lupus, and they have also used it in some other modalities. And what they did is that they, again, used the same patient's own cells, autologous, and they transduced with the lentiviral anti-CD19 vector, and then after lymphoablation with the fludarabine and cyclophosphamide. So the results, so this is about a 3-month follow-up paper that was published in Nature, and it showed that there was a deep depletion of the B cells. So the B cells which can be hiding in the tissue, which are not penetrated as much by rituximab, were indeed wiped out by giving the CAR T cells. And here you can see the SLE2K, which is an activity index for lupus, shows that there is a significant improvement in all 5 patients at the 3-month window, where the colored bars are large bars, and then the smaller bars are almost non-existent bars, are the 3-month follow-up. So extremely important or extremely impressive response. And then the remission was according to the DORIS criteria, which was achieved in all 5 patients after 3 months. And it was very well tolerated. There's only mild cytokine release syndrome, which is associated with much more higher frequency and severity in when it is used for other indications such as lymphoma and such. All righty. So I'm talking fast because I know that I have to cover a lot, but if I'm talking too fast, just give me a sign and I'll try to slow down. Alrighty. So this is the second, and the reason I selected this one is that it's is to just sort of convey a point that how creating registries and cohort are so helpful. And this study was from China, where they are following this cohort of lupus patients, and this is a huge cohort. Of course, you know, China has a huge population, but they were able to follow these patients for 10 years or so, and close to 1,600 patients were followed up. And the reason they did this study is to try to see if they can do a predictive modeling. So not only this study caught my eye because of how the predictive modeling, the statistics was done, and also how the methods were done. And if anyone would like to do a research study here in Pakistan, this will be a good study to sort of look at in terms of the disease, the method. So as Dr. Amr Hamid was saying, that you know, low resources with high impact. So these type of studies can be done. So what was this study? So this was a study to look at the risk prediction modeling. And what they did is that they looked at the onset and overall lupus nephritis risk among patients with lupus, and how we can predict it. So but they divided their cohort into training model and then validation cohorts, and then they validated their risk modeling, and they find by the multiple regression analyses that having a male sex, anti-double stranded DNA, and age of lupus onset less than 18, as well as the lupus duration, were risk factors to lupus nephritis. I mean, this is, we all pretty much know that, but at the same time, they just were able to create a composite marker of this, which is they have used an acronym of RIFLE LN, and about 60% of their patients develop lupus nephritis, and 45% in the first year. Maybe this is a little bit of a less generous. We usually see a little bit higher markers. So, but okay. So this is the composite index based on the male, age of onset, and anti-double stranded DNA. And then you can see that the ROC curve, the area under the curve was 0.7, and which is a pretty good prediction of who will go on and develop lupus nephritis. So that is number 2 study. Let's go to the number 3 study. And this number 3 study is again something that is coming out of the Hong Kong group. And the Hong Kong group, Dr. Mock has been long-term proponent of using triple therapy to treat lupus nephritis. And they have shown for the first time initially about 20 years ago that it is safe and effective. And now this is a long-term follow-up of how you can use a triple immunosuppressive regimen, and we did talk a little bit earlier about this in the lupus nephritis lecture. So with this, what they did is that patients with either 3, 4, and 5 lupus nephritis with proteinuria, which was persisted despite triple anti-immunosuppressive therapy, which is tacrolimus, prednisone, and mycophenolate mofetil, in a minimum duration of after 3 months, and then they identified and included them analyses. The numbers were small, about 22 patients, and they looked at patient characteristics, lab parameters, and clinically significant events. And then what they found is that the proteinuria, which is one of the most reliable predictor of response, at 3 months was still high, but at 6 months was a significantly improvement. And as you follow them through along the x-axis, and you can see that at 60 months, which is 5 years, there is a significant sustained remission of lupus nephritis in these patients while they were using the triple immunosuppressive regimen. So what we can say is that there is a significant proteinuria reduction at 6 months, and it's sustained, but also that the renal survival rate was pretty impressive. So this gives a lot of hope. And just to kind of plug in our own study is that one of the students from Jinnah Sindh Medical University was working with our group, and we did a meta-analysis, and the abstract is being presented at this conference, where we have also shown that using a multi-targeted approach does help. So please go and stop. Bisma is here, and you can look at her poster where we have shown similar results by doing the meta-analysis. So the adverse events were pretty comparable, and I think I was very impressed that how the adverse events were not as commonly seen as you would expect. Obviously, with triple treatment therapy, you will expect that the infections were on a higher side, and as you can see that. But most of the infections were treated with single dose of, with oral antibiotics or IV antibiotics, but there were no deaths in this group. There's some worsening of hypertension and so forth. Okay, so this is another study which is done in India, actually. And again, the reason I picked that study is that this type of studies can easily be done in any large academic centers in Pakistan. There is no reason we cannot do these type of studies. And it was published in one of very good lupus journals. So looking at the serum interferon alpha and see how it can predict in-hospital mortality in patients who are admitted with severe lupus. So patients who had lupus got admitted, they looked at them, and they make sure that the other reasons for their admission have been ruled out, i.e. infection and so forth. So any patients, they know that these are acute severe lupus patients. And what they did is that okay, thank you. They looked at the serum interferon levels as a biomarker for in-hospital mortality. And what they did is that they looked at 90 patients who were hospitalized, and the levels were compared between those patients who survived, who made it, and those who did not make it. And then they compared with the traditional clinical and serological markers, and see that which was a better predictor of mortality. And interestingly, and I was surprised by looking at their results too, that the SLE, the anti-double-stranded DNA, antibody titers, and serum interferon levels were high, and C3 were lower in the non-survivor, which is very obvious. But at the same time, when we looked at the cutoff of serum interferon level at 140, they did find that the specificity and sensitivity of this was much, much higher as compared to the traditional markers. And again, they're looking at the area under the curve, the AOC curves, the predictive ability of serum interferon was extremely high, and it was 0.92, which is like unbelievable for any biomarkers. So, so look at the top line. At the purple line is looking at the serum interferon levels, and the rest of the traditional biomarkers that we see, the ROC curves are much lower, but the interferon is highly predictive of mortality in patients with acute. And then there are multiple other studies have been done now, which shows that interferon is a good marker of severity in lupus patients. Okay. And so this is the study which is just published, and actually while we were on the flight from Lahore to Karachi, Laura was sitting next to me, and then I showed Laura, and then turns out that she is one of the, Dr. Lewandowski was one of the co-authors on this study, so I said maybe we should include that, and I think it has clinical relevance. So this is from the CARA network, which is the childhood arthritis network in North America, where they looked at the renal response outcomes of urolupus versus the traditional NIH cyclophosphamide regimen in treating patients with lupus nephritis. So this was a retrospective study, and this is the study design where you can see that they have looked at, compared the 58 patients, and this is childhood lupus patients. The mean age was about 12 years or so. On my right side is the urolupus, and the left side was the modified NIH regimen, and they looked at the data on baseline 3, 6, and 12 months, and looking at the complete response. And I must say that the response rate that they have used was very strict as compared to what we are usually using. And the complete response rate was GFR more than 90 or the UPCR of less than 0.2. And on the partial response was very similar to what traditionally being used. And the results showed that the patients who are on the Eurolupus cohort, about 22% had complete response, with the NIH about 40%. But when they did the multivariate analysis, they found that the confidence interval was crossing 1, so it was not significant. The complete renal response of Eurolupus was 0.76, and partial was 1.35, but was not statistically significant. So they concluded that that the benefit of the NIH is not there, but or on the flip side, you can say that the Eurolupus regimen can be used effectively for patients who have childhood. But I think we have to kind of take this with a grain of salt. One is that it's retrospective study, and the second is that as we know with lupus nephritis, 12 months may not be enough to see whether there will be relapses or not. And again, numerically looking at it, even though statistically it was not significant after doing the multivariate analysis, the complete response was 20% in the Eurolupus, but 40% in the NIH. And of course, I have the bias from using the NIH regimen. And also the point I made about 12 months. Okay. So now switching to vasculitis, and Raza made my job very easy because he covered a lot of things there. But this is something that was just recently published, which is looking at the reduced dose versus high dose regimen to rituximab remission rates in ANCA-associated vasculitis. And this was the predefined 2-year follow-up of the initial study that has shown that the reduced dose of glucocorticoid was as good in maintaining remission in patients. And by the way, these are the patients who have non-severe ANCA-associated vasculitis. So these patients were, this study was published in JAMA initially, and this was the first study. I just put it out there for reference, which shows that this was about 21 hospitals in Japan, and equal number of patients in each group, and either the reduced regimen or the high dose regimen. The primary outcome was remission rate at 6 months. And as you can see at the pie graph on the extreme left, that was 71% remission was in the reduced dose regimen and about 69.2% in the high dose regimen. So this was at the 6 months. And then, okay, so, and this is the 2-year follow-up. And the 2-year follow-up again shows that there is prednisone discontinuation rate was about 90% in the reduced dose, which is a very good thing, and the high dose was 15%. The relapse rate was was a little bit higher on the reduced dose, but it was not statistically significant. The serious adverse event, as you would expect, was much lower in the reduced dose as compared to the high dose, and there were 2 deaths in the reduced dose and the 5 in the high dose. All right, so my time is almost up, and I promise that I will finish in time, so I'll try to keep my promise, especially on the Friday. So this was a study which was recently published on New England Journal, and now looking at serilumab, which is IL-6 blocker for PMR during glucocorticoid taper. As we all very well aware as clinicians, that when we taper glucocorticoid during after treating PMR, there is a high incidence of relapse, and that always been a challenge. So tocilizumab has been used, and then serilumab is being used. And then looking at this, there was a 1-to-1 ratio of placebo versus serilumab in patients who were on PMR. There was a scheduled predetermined prednisone taper, and then the outcome was sustained remission at 52 weeks. And then the outcome was clinical CRP and GCP taper. And of course, CRP, sometimes you can be fooled because when you're blocking IL-6, it's downstream, so CRP can be falsely lowered in patients who are on IL-6. So I just wanted to put it out there. Okay. So looking at the sustained release, serilumab patients have a much more significant sustained relief, remission at 52 weeks as compared to placebo. When you're looking at the safety profile, more neutropenia, arthralgia, diarrhea, and adverse event leading to treatment discontinuation was noted in the drug arm as compared to the placebo arm. But the cumulative dose was significantly lower in seralutinib as compared to the placebo, even less than half there. And the better quality of life was reported by quality of life measures in patients with who are on IL-6 blocker. Okay, this is the last. So this is about the prophylaxis, if we use prophylaxis for PGP patients or not during rituximab. So these are not disease specific. Anyone who was getting rituximab for any type of autoimmune diseases, they combined that and then looked at whether doing prophylaxis is a good idea or is not a good idea. So by doing this study, what they did is that they look at the ones who have received the prophylaxis versus the one who did not receive the prophylaxis, and looking at risk-benefit assessment, whereas there was more benefit of doing the looking at the number needed to treat to prevent one PJP versus number needed to harm for one severe adverse event. So when they compared it, on the top part of the chart, you can see that number needed to prevent one PJP was 146, and number needed to harm for one severe adverse event was 85. So with that part, they have concluded the potential risk of prophylaxis outweighs the potential benefit. So sort of suggesting that may not be using it. But then I think they did a little bit more sub-analysis, and they're looking at that if there is a subset of the patient who may benefit for using benefit by using the Bactrim prophylaxis. And they did indeed find that the patients who are on higher dose of glucocorticoid in addition to rituximab, in those patients it does make sense to use Bactrim as prophylaxis as opposed to broadly using it. And I think the other thing that I have not put it here is that in our practice we use a lot of rituximab, cyclophosphamide. We have not seen as much pneumocystis, and this large study also showed that the incidence of PJP was not as high. So what were the risk factors for developing pneumocystis, which is a sub-analysis of the study, was that patients who have ANCA-associated vasculitis as a diagnosis, when they received rituximab, it was a much more higher incidence. The odds ratio was almost 4. And patients who were receiving high dose of glucocorticoid, the odds was extremely high, 16. And then it was statistically significant. As you can see, the confidence interval was very broad, but still it was significant. The incidence of the PJP in the control group was only 7, in the prophylaxis 4, so again a very low incidence. The severe adverse events were much higher in the prophylaxis group as compared to the control group, and that's why it was not recommended across the board. And so this is my summary. So I'll be happy to share the slides. But so the first thing I said is that the data suggests CAR T-cell therapy is feasible and tolerable and highly effective in patients with lupus. The second study, the RIFLE-LN, showed that the composite measure of male sex, anti-dsDNA, and early onset of lupus can potentially predict lupus nephritis, and it can also guide our treatment and disease monitoring, so kind of looking at the future. The third thing I talked about was the triple immunosuppression using TACRO, MMF, and PRED was effective and well tolerated for patients with lupus nephritis. And serum interferon alpha is better in predicting in-hospital mortality compared with anti-DNA and SLE in SLE and complements. And this is a study done in India. And then we talked about the low-dose cyclophosphamide regimen in childhood lupus, and seems like it is at least non-inferior to the NIH regimen. The low-dose glucocorticoid is effective in remission, and long-term use of remission maintenance might not be necessary in MPO-positive non-renal ANCA-associated vasculitis. Patients with relapse of PMR during GC taper, treatment with IL-6 results in sustained remission and reduced cumulative GC dosing, and this was a very significant study, I thought. And then the benefit associated with primary PJP prophylaxis outweighs the risk, except for patients who are receiving the high-dose glucocorticoid treatment. And patients who are on who have ANCA-associated vasculitis are much more higher risk of pneumocystis as compared to other autoimmune diseases. And with that, I end, and thank you so much for your attention.
Thank you, Dr. Hasni.